Hello, I'm Beth Hogue, Chief Operating Officer at Trinisys, and we are honored to be a part of this year's Tennessee HIM Summit. At Trinisys, we are focused on providing market-leading technology that materially improves our clients' operations by delivering a range of solutions for healthcare, insurance, financial services, and state Medicaid programs. Convergence, our core product, excels at connecting disparate systems, removing repetitive tasks, and streamlining multi-system workflows to improve efficiencies and operations. Built on the foundation of convergence, Clearview addresses the growing need for a reliable, vendor-neutral platform to archive and migrate clinical, financial, and operational data for the hospital and health system market. We hope that you will stop by our sponsor room to learn more about us and how we can help your organization. Without further ado, I would like to introduce COVID-19. Act locally, think globally. In this session, a group of experienced, well-respected healthcare leaders will discuss the pandemic and the role Tennessee has played in it. I hope you enjoy the session.
Good morning, Tennessee HIMS. Jay Cannon here, principal at Trinisys, and I will be your moderator for the panel COVID-19 Beyond the Clinical Impact. We're going to talk a little bit about clinical impact, but also the headlines. A lot of the information that we know has been confusing, but also what has borne out around science and the facts. Also, how that has impacted provider organizations, public health, as well as IT innovation, for which we all have an interest being associated with Tennessee HIMS. And so with that, let me do a very brief introduction to this star-studded panel that we have today, starting with Dr. Neil Patel. Dr. Patel currently serves as Chief Information Officer, Health IT, and Chief Health Information Officer for Vanderbilt University Medical Center. Dr. Patel has extensive health, IT, and clinical operational experience. He received his medical degree from the University of Southern California and completed his pediatric residency and critical care fellowship at Children's Hospital Los Angeles. He joined the faculty at Vanderbilt in 1997, as well as earning his master's in public health from Vanderbilt University Medical Center. Tommy Ragsdale currently leads strategy and trust platform services at the Center for Medical Interoperability. Tommy leads the center's efforts coordinating the medical device vendor community with health IT application developers, collaborating around the center's interoperability architecture. Prior to that, Tommy spent 10 years serving in the United States Marine Corps as a naval aviator. Tommy has a master's in business administration from the University of North Carolina, Chapel Hill, and his undergraduate from the United States Naval Academy. Tommy, thank you for serving your country. And last but not least, Dr. Stephanie Bailey. Dr. Bailey currently leads and manages resources for the College of Population Health at Meharry Medical College. Additionally, she works with Metro Nashville Public Health Department as they respond to the COVID-19 pandemic. From 2006 to 2011, she served as Chief for Public Health Practice for the CDC in Atlanta, Georgia. Dr. Bailey also held the position of Director of Health for the City of Nashville, Davidson County. And Dr. Bailey earned her undergraduate in psychology from Clark University, her master's from the College of St. Francis in Joliet, Illinois, and then, of course, her MD from Meharry Medical College, Nashville, Tennessee. And she performed her residency with internal medicine at Grady Memorial Emory University Hospitals in Atlanta, Georgia. Her purpose in life is to lift people up so they can soar. I am ready to soar, so let's go ahead and jump right in and hear from our panel. Well, let's get this conversation started and welcome Dr. Patel.
Well, thank you for having me, and it's a pleasure to try to hopefully provide some insight from Vanderbilt University Medical Center.
You bet. Well, thank you. I'd like to start with a couple of positioning questions before you take over, if that sounds okay.
Absolutely.
Dr. Patel, I don't think I am the only one, but the information around the COVID-19 virus has been not only confusing, but conflicting. We would like you to share with us some reality around that as far as the infection rates and the spread of the virus. And then secondarily, from your clinical perspective, what's been the impact of the virus at the point of care? And how have provider organizations been required to respond in turn?
Well, happy to take that first question. And I think with all of the data that's available to us, many individuals across the country have become armchair epidemiologists. So to kind of help, I think we want to just go back to basics. And this is a graphic that basically shows where our population density is across the nation. So these spikes are not virus spikes. This is just a view of where is the majority of the population in the United States. And I wanted to kind of hone in on this a little bit. And this is a slightly different view. If you look at all the red areas feature the population that is greater than all of the gray area combined. And take a look at that for a second, because this is just pure population data, has nothing to do with coronavirus. But then if you look at how our nation looked with respect to coronavirus COVID cases back in April, gosh, you see that the red, where the majority of the cases were where our population was. Not surprising. It's a very contagious disease. It entered in from our coast, or it entered in to the high dense areas, and you may not have had much spread in the wide areas. The key about this was that as we moved forward and it spread, the unfortunate part was that we didn't control it. And so this is what it looks like now across the United States in terms of the total number of cases that we have confirmed. And you could say, okay, we have it in our high dense areas and now it's in these other areas. And how do we look at this? And the problem here comes down to is because everything has been so politicized, you could twist the data to make whatever point you want. But all in all, the way I look at it is COVID has almost become endemic. It is everywhere in our country. And the question comes out to is just how fast is it spreading, and are the healthcare systems in those areas able to keep pace with it or not? That's the fundamental question. Until we have a vaccine, it will spread. The question really comes down to is how fast will it overwhelm our resources, and can we at least protect our most vulnerable for as long as we can, especially our elderly in the nursing homes? And that's what it really comes down to. And so if you look at normalizing some of this data, this is actually the confirmed cases per 100,000. So it's normalized to 100,000 population. And now you see where the new cases are really multiplying fast in the area of the country that didn't have much population. But if you don't normalize to the population, it can go hidden. And that's some of the intriguing part about this disease, that unfortunately, instead of just looking at objective numbers and science and good public health measures, people have kind of treated this no different than electoral college votes, and it becomes difficult to really translate into action, and it is inherent to some unconscious as well as conscious biases.
Sure.
Pivoting a little bit to our local region, we in Tennessee and in the Nashville region have actually done fairly well overall. This graph shows where we had our big peak after the July 4th weekend when we started to relax our social distancing and masking pressures, and we kind of settled down, and in the August timeframe, everybody was feeling pretty good. But I think the key issue is if you look at those curves after October 1 and what we're seeing now, we are steadily rising. And that's what has us the most concerned, because fundamentally, we knew that COVID was going to spread. Again, as I said before, can we keep it at bay and have a steady stream of patients with COVID, most of which will acquire the disease, quarantine at home, recover, and go about their life, some of which may require hospitalization, and that all of our regional hospitals would have enough space for them while continuing to care for all the other patients that we routinely care for. I mean, at Vanderbilt University Medical Center, we routinely run, before COVID ever happened, at 95% capacity. So now all of a sudden, if we have 20 to 30 to 40 COVID patients, or it starts to outstrip some of our beds, what other patients won't be able to take care of? That's the fundamental balance that we're trying to fight. I'm going to pivot to the fact that right now we are beginning to be getting worried about what this graph shows. From the early days, we had very high spread. This is the R0 disease, how many people each infected person can infect. Got it under control, started to spike up a little bit in that July timeframe when we had a lot of cases on that previous graph. But then in the August timeframe, really got it under control in the sense of the spread was very steady. And this was the time that in our medical center, our inpatient census of COVID patients was in the mid-20s, low 30s, and very stable. Patients would come in, most would get better, they would transition out, and new patients would come in, and it was just a revolving door of those patients coming in and getting treatment and going out. Unfortunately, most recently, that number has started to rise, and now for the first time, we're seeing the number of inpatients in our hospital at almost the same rate that we had them back in the March, April timeframe. And at that time, we had plenty of beds because all elective surgeries were canceled and there was everything was focused on COVID. Right now, we don't have that ability, and so now we have to balance those capacity measures. So that's where we're trying to do some innovative things so that our frontline providers can not only continue to care for this very sick population that comes into the hospital, but also for all of the other care that our medical centers have to provide. So fundamentally, one of the things that we did to try to mitigate some of the inpatient beds being needed for COVID patients is under the leadership of one of our internal medicine physicians, Dr. Victor Legner, as well as our leader of our home care Vanderbilt Health Services, LB Brown, and our population leader, David Posh. We, soon after the first case of COVID in Tennessee and in Davidson County, we actually created the first, what we call COVID to Home program enrollee. What we realized was, especially after learning from what was happening in the Northeast during the initial wave of COVID, is that many of these patients were going to be hypoxic. They just needed to be monitored. Most would get better, and we didn't need to take up a hospital bed if we could just keep close tabs on them. So to that end, a multidisciplinary team of individuals came together and formed a program called COVID to Home, where we could rapidly discharge patients, check in on them on a daily basis, have a way for them to contact us, and then come back to the facility, to the institution if they needed it. And you can see over time that initially we had a lot of patients, and then it follows the same curve that we did with our up and down COVID. And over the time of this past 7 months, we've enrolled about 200 patients into this program, meaning that we have saved a lot of hospital days for these patients, so that it allows us to take care of the sicker patients.
What a great example of clinical innovation on the fly.
Yeah, and I mean, just kudos to our clinical and operational leaderships, and we were attempting to support this with registry and keeping track of these patients in our system, as well as providing the infrastructure. The neat part about this is the sources of these enrollments were patients who were in the hospital that basically did not, only maybe had a slight requirement or just needed to be monitored. We give them a pulse oximeter like you see on TV that they can report their findings. 11% came from the community, and 7 were able to be discharged directly from the emergency room to this program, and as a result, saving a hospital bed for somebody who might need it, who had more acute disease. And so this was a good example of really, in a rapid fashion, adjusting the way clinical care is delivered. It was easier to do when the entire institution had a singular focus. I mean, think about it. If we had to do this during normal times, it would take at least 6 to 8 months of committee meetings to come up with this process. And this was really put together in under a week during full attention. So I thought this was a good example versus all of the other stuff that most people have done that are that is very similar of how Vanderbilt has responded on the front lines to not only care for the patients with COVID, but also to make sure that our institution has the capacity to take care of all of the ill patients that need our services in the Middle Tennessee region.
Well, very impressive. And Dr. Patel, we've got a couple minutes left, and I apologize for being compressed on time. Do you want to hit a couple of the other high points that you'd want to make sure our audience received as takeaways?
Well, I think the most important point, as the data shows, COVID is all around us. We just have to be good stewards and practice good public health measures. Try not to get other people sick. So how can you do that? Right? Fundamentally, at the end of the day, nobody wants to get somebody else sick. So wear your mask. If you look at all of our frontline workers in the hospital, all of our nurses, physicians, respiratory therapists, environmental services workers, they're all wearing a mask in the hospital. And as a result, we have very little spread of COVID, despite all the COVID that's around us in the hospital. In our schools, we have very little COVID spread in our schools, despite all the worry, because everybody's following directions. Where we do see the spread is when people let their guard down and forget about social distancing because they think they're safe, or that it's okay because I know the person, so therefore they're not going to get me sick. Well, they didn't mean to get you sick. It wasn't on purpose, but sometimes people just don't know that they might have just been exposed to somebody else, and now they're able to pass it on to you without their knowledge. And
well,
so
thank you. And Dr. Patel, let me end with this, if I can ask you one more question. How do you see, and I know none of us has a crystal ball, but how do you see this virus playing out in months and year ahead? I think that's the question everyone's asking.
Well, the good part is the treatment for this virus between the antivirals, the antibody cocktails that are the various drug companies that Vanderbilt is doing clinical trials on today, as well as the vaccine work in which Vanderbilt is also participating in the clinical trials, that all of those things are bearing fruit. So while the virus will be with us, I'm fairly confident that our treatment of it is getting better and better. Our mortality rate is getting better and better with this. And I feel that the vaccine will be available, hopefully by the turn of the year. The question then will be, how do we get it to the right people in the most timely fashion, and then eventually get it to everybody? But I think eventually we should be able to be in a space where we don't have to worry as much about this as we are today. But it is something that's going to be with us for a while.
Right. And as you said earlier, hopefully we'll have the political cycle behind us and be able to look at that very objectively.
Yeah, and I think it doesn't matter what your politics are. At the end of the day, we just have to remember this is an infectious disease. It's going to do what it's going to do based on biology and physiology, not about what a person may think
Sure.
about what it's going to do.
Sure. Well, Dr. Patel, thank you. We are going to move on with the panel and greatly appreciate your insight.
Appreciate it. Thank you so much.
Well, let's now turn things over to our next panelist, who is Tommy Ragsdale. Welcome, Tommy.
Thanks, Jay. It's great to be here and to talk to this audience.
Well, thank you in turn. Okay, our audience is anxious to hear from a technologist in regard to the COVID-19 situation. And if you don't mind, I thought I might start with a couple of questions to you as well, if that's okay.
That sounds great.
All right. Well, the first one I think is relatively specific, and that is, what does PPE readiness now and in the future look like, given us progressing through this virus and pandemic? And then secondarily, how has COVID, and this is the one I care about, how has COVID-19 impacted, in your mind, IT innovation? And with that, I'll hand it over and have you make some comments.
Sure, thanks. I think both those are obviously very critical questions to where we are today, where we're going to be in the next couple of months, in the next year, et cetera. And I think that at least my answers to those questions will be kind of interwoven in this presentation, and we can probably talk about it a little bit more outside of that. I'm going to jump right into some of the work that the Center for Medical Interoperability has been undertaking over roughly the last year to 15 months, and it's a project called Together for PPE Readiness. Together for PPE Readiness, as you can see on this slide, is a true public-private partnership between the CDC, an office inside the CDC called the National Institute for Occupational Safety and Health, and the Center for Medical Interoperability and its members. The effort was to address PPE readiness, meaning do we have the right kinds of PPE in the right places for the right people as a nation, as a national system. And that's what NIOSH and NPPTL is charged to do. And the Center for Medical Interoperability's members and our mission were what was really intriguing to the CDC. And for those of you who don't know who we are at the Center for Medical Interoperability, I'll get to that in just a couple slides. But I wanted to hit this right off the bat, the public-private partnership effort here being really important. So to address personal protective equipment, its availability and its usability, the CDC, NIOSH have been working on this challenge for many years. It didn't start with COVID-19. In fact, we, strangely enough, began this work with that group September of 19. So we signed that contract to begin that work about 4 months before anything was really coming out of China, and about 6 months before anything was really happening here in the United States in March. They were driven by the 2009 H1N1 instance and the 2014 Ebola instances. Really started to say, what happens in a pandemic to our systemic readiness and ability to protect our healthcare workers? Some of the work that the CDC undertook before engaging with us is outlined right here, and it was a part of the Pro-Employee Health Protection Survey. Some of the audience members may be a part of that, or may have been a part of that, as it was a research effort led by Vanderbilt and by many of the healthcare systems hospitals in the mid-state area. TriStar played heavily in it, Vanderbilt, St. Thomas, the St. Thomas system, and a couple of the other regional hospitals around here. And it identified a lot of challenges, but things that really brought the CDC to us was the lack of trusted exchange of data, trusted exchange of inventory data. And that is what the Center for Medical Interoperability was designed in the first place to address. Trusted exchange of data at the bedside is the center's original mission, which then expanded into an inter-organizational effort. Again, for those of you who don't know, we're a laboratory, 501c3 cooperative R&D lab, led by health systems. And you see health systems right here that are members of the center and have board seats. There are others that don't have board seats. Not all of these health systems necessarily participated in the Together for PPE Readiness project, but a number did. I believe it was 6 or 7 health systems were initially involved. Once COVID-19 hit, the CDC wanted us to expedite, as with anything, right? You got to start hitting the gas pedal and making this happen faster. So what we did was engaged a smaller set of that health system membership to see who wanted to sprint with us, and we came out of that with a few: Nashville General, Northwestern up in Chicago, and CHS. What do we do for those organizations? Well, we built some tools, and that's what I'm showing you right here. And these are simply software tools that show information about PPE for a hospital. Now, this could also be beyond a hospital. The CDC obviously was really interested in regional looks and national looks. So we built the tools to identify over geographic areas that could be predefined. In this image, you see HHS regions. That was obviously really important to the CDC and HHS at large, and as well as the White House. And some of the work we did was focused on that. But the user for this wasn't just the CDC, it was also the hospitals and health systems themselves, the infection control teams, the supply teams. And one of the desires was, if we get into a really tight situation, some people in certain parts of the country may have more PPE on stock and might not necessarily need it than others in other parts of the country. And the CDC, NIOSH wanted to be able to affect that type of exchange if possible. So how do you do that? You need data. You need information to be able to see it. Another tool that we brought out for the operational effectiveness of those supply teams and infection control teams and others was some forecast modeling of, at current rates of consumption, what does it look like for your, on this image, 95 masks? Or we even took the approach of making kits, if you will. So if I have a standard kit as a hospital or health system for dealing with COVID-19, that might include an N95 and a certain gown and a mask and boot covers, for instance, I could build that as well and start to predict what that looks like. Now, you may ask, how does all of this happen? Well, this is where taking a step back and looking at the Center for Medical Interoperability's mission really comes into play. So we were established to accelerate the seamless exchange of information to improve healthcare for all, specifically at the bedside. You see this image right here is our healthcare trust platform, the technical architecture for it. You see a network that's built by participants in that platform. You see shared trust services at the top, and then you start to see implementations at the bottom, specific hospitals, inside an ICU, like in that inset right there. All of these need trusted exchange of data, and that's becoming even more important with things like 21st Century Cures Act, the ONC and CMS rules for data exchange, and the, should we say, perhaps intrusion of big tech coming into healthcare, because that's what they do. That's what they do really well. And the center's mission was to bring this standardized platform by its members, of its members, to the industry. I could talk more about that, but in respect to time, I wanted to get a little bit more technical image up there for the really technical folks in the audience. Again, I'm not going to go through each one of these things, but I wanted to throw it up there to say there is some real meat behind this trust platform. It's a data agnostic trust platform. We were never in the business of building tools for PPE. We were just in the business of trusted data exchange. We had a great use case that needed these attributes to assist a problem that the CDC had identified and then became manifest during our project. So I can talk about each one of these obviously in depth, but not at this time. For those of you who have questions, please ask after, or you can engage me later on. I wanted to throw up a little bit more of a specific instance of what this platform looked like for this specific use case. You can see some of the participants in purple there, hospitals or health systems. Their appropriate inventory systems attached to the platform through a trusted protocol. Some health systems also used ordering systems to really give a better picture. The image below that is just a different deployment option that we use to give variability there. And then you see some of the services over to the right that we brokered for the sake of this use case. And the tools that you saw before are that dashboard prototype and others. What did it look like? What did we end up doing? Well, these bullets right here show you what our ultimate deliverables were for this project. We ran for 14 weeks, data flow out of our health systems into our data brokerage process, and then developed reports up to the CDC that were blinded. And they used that obviously for response mechanisms, but also to see what was possible in trusted data exchange. The platform itself, ready for other use cases. The governance around it, that participation in common data use agreement is huge, because many of us in healthcare in this room know that it's not so much about the machination of data exchange, but the governance and the agreements that go around it, and how healthcare needs to take a step forward in that respect to be on par, at least technically speaking, with other industries. So I could talk about each one of these bullets in depth. I don't want to do that right now with respect to the rest of the panelists. So I'm going to hand it back to Jay for now, and happy to answer any of your questions.
Great. Well, Tommy, I think we have about a minute or 45 seconds left, and incredibly impressive. And I guess along the lines of this topic of innovation and the collaboration in which you brought together and the diversity of those participants, in regard to innovation, what did you find, or the center found, is that key element to cause those organizations to coalesce and to work toward this effective solution?
That's a really interesting question, and I'll try to condense this. When we first were approached by the CDC, again, pre-COVID, and then addressed our members to see who was interested in this project, there was interest, for sure. Everybody saw the value in it. But it was maybe tepid, is a good way to put it. Then when COVID news started coming out of China, everyone got really interested really quick. It was a bit of a double-edged sword because once COVID came across the pond, there was a lot of operational demands on those health systems. So I guess my point is there's got to be a middle road. You got to find that sweet spot between where they're operationally overwhelmed by whatever it is they're dealing with at that time, or and the lack of interest, meaning something might not appear relevant at any given time.
Necessity truly does drive innovation at times. And again, very impressive. Tommy, thank you. We will go ahead and move on with our discussion and look forward to the Q&A session here at the end.
Great. Thank you, Jay.
Well, I am really excited to hear from our next panelist as she shares some unique thoughts from a public health perspective. And so with that, good morning and welcome, Dr. Bailey.
Good morning. You know, I could have done 20 plus slides for the issues of contradictions, but I'm very respectful of the limited time we have for our presentation. COVID is definitely a real public health issue, but the hue and cry was for hospitalizations needs, not that of public health. For example, case investigation, contact tracers, real-time surveillance, and enhanced doctor reporting, etc. You know, the things that assure public health infrastructure. From the start of the pandemic, about late January, I had maintained in the forefront of my mind that something is not right about this. At the time, the virus was not floating in the air. Everybody was not infected. The number of reported hospitalizations were not outnumbering the number of beds by a long shot. I recall seeing the number of reported numbers and thinking about the number of hospitals just in Davidson County and the net total of beds. Where was the panic? And the Institute of Hospitalization's medical system simulation report, which turned out to have overestimated this number of people to be hospitalized by a large margin, was one of the bases of the huge concern. So we're in panic mode and we are not doing what we know to do. Our basic core template and response was threatened because of this new thing. What strain are we dealing with was never part of the conversation and still is not. The SARS virus strain was known to us in a matter of 3 months when it came on board. Coronavirus was to have been generally ubiquitous. We reacted with little information not coming forthright from China and the WHO because people were becoming sick and infected and they were crying out. From a public health view, this was definitely a huge concern. Anytime there is the potential to prevent, contain, or eliminate a threat, public health discipline is at work. But over the time period, as everyone is trying to stop the spread, even saying that the virus had to be totally eliminated before we can assume a normal state, information became contradictory as policies and jurisdictions were being made. And once you start on a policy trail, it seems hard to, to readjust. Many places hunkered down or half hunkered. Secondary health issues began to surface in an extraordinary manner. The economy suffered, and lives are dramatically disrupted. There are spikes in opioid deaths, increase in suicides, increase in depressive episodes, decrease in access to hospital care for things like regular cancer treatments, and up to 38% loss of learning, knowledge, and retention in school aged children. Just last month in September, it is reported that 6,500 intentional or unintentional injury, poisonings, and other comorbidities. The panic within the pandemic began to grow. So let me share some of the scientific edicts or opinions from the headlines, as they say. So, CNBC, that the virus spreads through airborne transmission, different from the initial. Droplets fall within 6 feet. Now, the virus can travel more than that 6 feet, especially in poorly ventilated rooms, and further, they can linger in the air 2 to 3 minutes. The Washington Post, it does not spread easily from surfaces. Yet Americans loaded up on sanitizers and wipes. Not a surface missed a wipe, because it was thought initially that you could get COVID from unclean surfaces. And does it spread from oral fecal? This is new revelation as of July 17. Let's talk about lockdowns. The New York Post, Fauci is talking about the policies seem to work. And from the current narrative that's floating around, you would think the policies that were put in place by the president have not done a thing, starting with the travel ban on January 27th. In the National Review, lockdowns may have had little effect. Certainly has been short sighted to have ignored the cost, especially since benefits are now in question. WHO on October 13th announced that lockouts are not necessary. Okay, now what? I do believe, as many others do, that lockdowns simply delay the natural trajectory of the virus. In this slide here, you see from the World Health Organization the advice on use of masks. Next, they continue in the next slide that says essentially that mask at the present, there's no evidence on the effectiveness. Later that same day, those kind of contradictory things came out. You may know someone who followed all the rules and still got infected with COVID. The president was in a super controlled environment and became infected. There is a CDC study that came out in July looking at 11 medical institutions, those who had worn masks, those who had not worn masks 14 days before their diagnosis. And it was found that 71% of those who always wore a mask became infected, and 14% of those who replied that they often wore a mask got infected. A later case control study showed the same incidence. In other words, the majority of those infected with COVID always wore masks. There is some data out there that states compulsory mask had no effect on curbing the Spanish flu of 1918. In September, our leading man of science, Dr. Robert Redmond, who's the director of the CDC, said that masks are better than a vaccine. Dr. Robert Redfield. February 29th, the Surgeon General said to stop buying masks. They are not effective to keep you from getting the virus. And on March 8th, Dr. Fauci agreed, saying, no reason to be walking around with a mask. Our testing. Here in the news, you see CDC reverses course on testing asymptomatic people for COVID now, when we know people with can transmit the virus who are asymptomatic. But here, September 18th, they're repeating something that they said again. What's happening in other places? In Sweden, 10 million people did not shut down, less than 200 cases per day through September. They kept most of their schools and businesses open, and a little over 1% of tests positive compared to greater than 7% in Northwest England. In France, 12,000 cases a day to date. In Spain, 10,000 cases a day. Hospitals are overwhelmed in the spring in Sweden and are practically deserted now. They look like the world we lost. Ireland and Scotland have record low death rates. Two new peer reviewed studies are showing a sharp drop in mortality among hospitalized COVID patients. The drop is seen in all groups, including older patients and those with underlying conditions. At the beginning of the pandemic, death rates for those hospitalized was 25.6%. That rate is about 7.5% of people who are dying. Our, our World Data Organization shows as of October the 14th, 2,500% more daily cases per million in the 7-day rolling average in the UK, 722% in the European Union versus only 21% in the US. 6.9% of COVID patients dying in the UK, 4.3% in the European Union versus 2.8% in the United States. The average daily COVID deaths since August 1st, 402 UK, 493% Eastern Europe, and 37% in the US. So is Europe still the gold standard? We look at the GDP slide, and you can see 2 slides back, please. The projected change in the GDP for if they had a single hit scenario in the yellow, and if they had an additional decline, they would have an additional decline in a single hit scenario. And you see where France is, Italy, UK, and the US is a minus 8.5. So we are doing better on the economic ground. When we look at the survival rate of persons, you do see that 0 to 19 years, they have a 99.997%. Could you get closer than 100 to 100%? And those who are 70 plus and older, they have a 94.6% chance of survival. So COVID is not a death sentence. There are other issues and some truths. There are other there's questions that are lingering, like are physicians pressured to list death as COVID, even when it is clear a patient died as a result of a car accident and just happened to have the virus? What is a legitimate COVID-19 death? Where is the science versus the politics? What is the science of fear? Is there so much success in this fear science that discussions of possibilities are prohibited? For example, hydroxychloroquine usage in the first 5 days of diagnosis. And I would pose the question to anyone who debunked that theory. If you were sick with COVID and you had a slim chance to none of surviving with uses of hydroxychloroquine, would you use it? I would go with slim. So, how are the metrics developed and based on what science? Is the virus attenuating? Why not? Most viruses do. So, 10 months into this pandemic, now what? We have some truths. We just saw the survival rate. We know people need to work. We know children need to be in school. They're greater than 70 to 75 still the most vulnerable. There will be another organism, even as deliberate attacks, perhaps. Vaccine is not a cure. 40% of people get the flu vaccine, 60% of children. Treatments have improved. High dose prescription strength vitamin D does work and reduces risk of getting COVID by 77%. Flonase is being bought off the shelf by those who are self medicating when diagnosed, along with zinc salts and N-acetylcysteine. When we come out of this, we do not want to look like China. COVID is not a death sentence. Everyone is building the airplane while we fly. Herd immunity has never occurred without a vaccine. Thank you for this, and I'm looking forward to the questions.
Dr. Bailey, thank you for enlightening us through your very unique perspective. And in light of time, we will now transition to audience questions. And I know there will be quite a few, as I believe I have some myself. Thank you again.
Thank you.